This is the Dartmouth Ski Patrol Outdoor Emergency Care presentation on backboarding, updated for 2025. This is actually part 2 of a much longer video. This is just the skill portion of how to do the skill. If you want to know the indications for backboarding or why we are still backboarding anyone in 2025, you should watch part 1. When providing actual patient care to a real patient, or especially when taking the final practical exam for the OEC course, you need to make sure that you assess the patient's circulation, sensation, and motor function, or circulation, sensation, and motion, or CSMs, in all 4 extremities before you start to manipulate their spine. You need to check all 3 of those components, circulation, sensation, and motion, in all 4 extremities, ideally before you go messing with anything else. This should probably be done before moving the patient's head into neutral alignment, unless airway is a bigger priority.
So I'm just going to check your circulation. Can you squeeze my hand here?
Yeah.
Is there any numbness or tingling in there?
Nope.
Cool. And the skin is warm and dry.
Yep.
Maybe the other side. Can you squeeze my hand over here?
Yeah.
Is there any numbness or tingling?
Nope.
Skin is warm and dry.
Yep.
Okay, so can you wiggle your toes in here?
Yeah.
Can you feel this?
Yep.
Is there any numbness or tingling in either of your feet?
No.
Awesome. I'm going to check the skin up here. It's warm, pink, and dry. Check the other leg.
Traverse pass, Bill.
Same here.
1218.
Skin is warm, pink, and dry. I would go ahead. We're going to go ahead and remove your helmet.
Okay.
You'll notice that the OEC textbook breaks down the process of backboarding into multiple individual skill guidelines. Each skill guideline does expect you to assure scene safety, take standard precautions, introduce yourself, and obtain permission to treat. They do not specifically call out the checking of CSMs between each individual step of the procedure. You should only check CSMs one time before you start working on the patient, and again when you've finished working on the patient. Do not need to do it after each separate step of backboarding. This is Skill Guide 21-1, Head Alignment. When you're in class, we have laminated copies of all of the skill guidelines, and you and the station facilitators should refer to these as they have a lot of detail within them. Kneel next to the patient's head, either to the side or at the top of the head. Place your hands on either side of the patient's head with the palms adjacent to the ears and the fingers supporting the jaw and the back of the head. Gently move the head so that the patient's eyes are looking forward and the patient's nose and chin are aligned with the sternum.
The scene is safe. I've introduced myself, getting consent to treat, and I'm wearing my standard precautions. If it's alright with you, I'm going to try and return your head to a neutral inline position. Will you just tell me if this hurts at all or what you feel? 3. Okay, let's try.
But wait, there's more. Never force the head into alignment. If the patient has muscle spasms in the neck, or if your movement causes increased pain in the neck, or numbness, tingling, or weakness in the extremities, or if alignment compromises airway or breathing, stop what you're doing and stabilize the patient in the position found. Continue to manually support the head while your partner applies a cervical collar around the neck. Cervical collar is not part of this skill. If the head cannot be moved into alignment, you may have to stabilize the head using a blanket roll, also not part of this skill. Do not allow the patient to move unless they are sitting or standing.
The scene is safe. The scene is safe. I have my standard precaution. Hi, my name is Kip. I'm with Dartmouth Ski Patrol. Can I help you? Yes. Okay, I'm just gonna put your spine in a more neutral position. Is that okay? Yeah. Okay. Taking C-spine.
This is Skill Guide 21-6, Helmet Removal. Assure scene safety, initiate standard precautions, introduce yourself and obtain permission to treat. If you are doing this as a separate skill station at the final exam, you should check CSMs in all 4 extremities before doing anything else. If you've already done CSMs as part of your assessment during a scenario, you don't have to do them again just because you're removing the helmet. Align the patient axially. Also, you should have already done this. Rescuer 1, manually stabilize the head and cervical spine by placing one hand on either side of the helmet. Again, someone should have already done that. Rescuer 2, carefully open the face shield and or remove goggles if present. Unfasten the chin strap and place one hand at the occiput, which is the back of the head, and the other at the chin, which is the front of the head. If blood is suspected, use standard precautions, which you should have already done because they're standard precautions, and we always do standard precautions. As an alternative method, rescuer number 2 places one hand along either side of the patient's head, sliding your hands inside the helmet so that the fingers are in position to support each side of the face up over the ears. Either method is acceptable. Remove the helmet.
I'm gonna go ahead and remove your helmet now. I'm gonna take your goggles off. Might be a bit bright. Okay. Unput your helmet. Bring in here behind. Then on your count, you're gonna remove the helmet.
1, 2, 3. Okay, taking back over stabilization.
Awesome. How's that feel? Anything feel different? No, feels great. Okay, awesome.
But wait, there's more. Remove the helmet. Rescuer 1 grasps the helmet straps or sides of the helmet and pulls them apart, spreading the helmet. Then pulls the helmet axially away from the patient's head, providing forward rotation of the helmet to ease passage of the chin guard, a plastic device that protects the mouth and chin area on some types of ski and other sports helmets, off the face. Rescuer 2 slides the fingers up to the occiput, which is the back of the head, or on both sides of the head over the ears and chin, ensuring that the patient's head and cervical spine remain immobilized. Continue to stabilize the head until a cervical collar is applied, which is not part of this skill. The most important thing to remember about helmet removal is as soon as the helmet is removed, the head is up in the air by like an inch to an inch and a half, and it will drop if you're not holding on to it. So whoever is holding the head has to support the weight of the head, which is about as heavy as a bowling ball. So as the helmet comes off, you got to be ready to hold the head up. Ideally, keep holding the head up while you position the C-collar. Have that ready to go so that you only have to move the head one time.
All right, Honor, now we're going to come in and remove the helmet. Charlotte, are you?
Yes, I'm stable.
You stable? All right, on 3, I'm going to begin to remove the helmet. 1, 2, 3. All right. Hat for warmth. All right, and I can take over C-spine.
1, 2, 3.
And we do carry hats in our in-service backboarding kits so that when we do a helmet removal, we can put a hat on and preserve some warmth, because hypothermia is a thing that is definitely known to cause morbidity and mortality in trauma patients. Skill Guide 21-2, cervical collar. Scene safety, take standard precautions. Introduce yourself, obtain permission to treat. Maintain or establish manual stabilization of the head and cervical spine, if not already done. Measure the patient and the cervical collar. Be sure to follow the manufacturer's specifications for sizing for each of the different collar types. You will learn how to do this. It will be demonstrated in the video. Apply the cervical collar. Open the patient's coat or shirt. Move any bulky clothing out of the way. Do not put the collar on over clothing. Slide the posterior neck portion of the collar behind the patient's neck, which is what posterior means. Swing the chin portion of the collar up over the patient's chest until it cups the chin. Secure the cervical collar using the Velcro closure and ensure a proper fit.
Okay, so now we're just gonna put a C-collar on to hold your neck in place.
Okay.
I'm gonna make sure to remove any bulky clothing. I'm gonna cut the neck gaiter. Then unzip some of these layers to expose the neck. I'm gonna measure the space here. About 4 fingers. Measuring the C-collar. He has a normal size neck. I'm gonna try to slip this under without disturbing him too much. Making sure the trachea is in line. How's that feel?
Good.
And you can see with the quick cut in the video that you really need to make space for the collar when you open up the clothing. Sizing the cervical collar using your fingers. You want to slide your fingers down the patient's neck and then measure how many fingers there are between where your hand stops and the corner of the jaw.
I'm gonna go ahead and measure the patient's neck. I've got 4 fingers here. 4 fingers.
And the 4 fingers go right where the red button came out. This is your lock. As you adjust your cervical collar, you push that into lock. If it's already locked and you need to unlock it, you can push it back out from the backside. Skill Guide Log Roll 5-7. Why this is in Chapter 5 and not in Chapter 21. Scene Safety, BSI. Introduce yourself, obtain permission to treat. Rescuers kneel on the side of the patient away from the backboard. An additional rescuer needs to maintain proper head and neck position of the patient. While maintaining stabilization, the leader, the rescuer on the head, calls the roll. The patient is rolled onto the side. The head and neck are in alignment with the spine. The patient is then rolled onto the backboard or stretcher, keeping the spine straight. A long axis drag is successfully used to reposition the patient.
I go 1, 2, 3.
You want to help with the spine?
Choke the spine.
Pierce, do you feel any pain or tenderness down here?
No.
Put him back down.
Okay. 1, 2, 3.
While you have the patient rolled up onto their side is a great opportunity to do your assessment of the posterior surfaces, including palpating the entire spine. Skill Guide 5-5, the bean/bridge lift. Scene safety, standard precautions, introduce yourself and obtain permission to treat. The rescuers kneel on either side, both sides of the patient. Rescuers place their arms under the patient. A rescuer or bystander prepares the backboard, which is going to get slid underneath the patient when you lift them. The rescuers raise the patient about 5 or 6 inches and lower the patient onto the backboard. Just like the log roll, you may have to then do a long axis drag and reposition the patient to get them properly centered on the board. Skill 21-3, the axial drag. Scene safety, standard precautions, introduce yourself, obtain permission to treat. Rescuer 1 instructs rescuers 2, 3, and 4 to slide the patient toward the foot of the backboard toward the rescuers on the count of 3. The rescuer's hands should be at the hip area, pulling the patient down to the foot of the board. You do not want to push the patient and cause their spine to fold in half because you're trying to push them by it. Rescuer 1 instructs the rescuers to slide the patient into the proper position on the count of 3. Pull the patient back up toward the head of the long backboard with rescuer's hands under the armpits on each side. Again, you're pulling the spine in the direction that you're moving and moving simultaneously. You may also have to lift up on the patient so that their clothing and ski boots doesn't get caught on the board as you move them. You repeat this process until the patient is positioned correctly on the board.
Down and to the right 2 inches. 1, 2, 3. Up 8 inches. Just straight up. 1, 2, 3. Okay, good.
Skill Guide 21-4, securing the patient onto a long backboard. Scene safety, standard precautions, introduce yourself, obtain permission to treat. Secure the torso first. Cross the straps from over the shoulder to just above the opposite hip. Tighten smoothly as the patient takes a deep breath. Do not tug or over-tighten. Appropriately tight strap should allow you to fit one finger between the strap and the patient and should never compromise the patient's ability to breathe. If you're using a commercial device, follow the manufacturer's directions. Pad any voids using towels, blankets, or clothing to prevent movement or twisting of the spine and improve the patient's comfort. There is usually a void under the knees that needs padding. This is how they want the chest straps. This is the picture from the textbook. Wait, there's more. Secure the pelvis and the extremities next. Beginning where the torso straps end to prevent gaps, cross the pelvis straps from above the iliac crest, the patient's hips, just below the level of the greater trochanter of each femur, which is the upper thigh. This ensures that the entire weight of the pelvis is contained within the straps and is properly immobilized. Alternatively, a single strap can be placed across the pelvis at the level of the pubis bone. Make sure it's on bony structures and not on soft tissue of the abdomen or genitals. An additional strap should be placed across the mid-thighs between the end of the pelvis straps and the knees. Place another strap across the lower legs. If the patient has a possible pelvis or hip fracture or an abdominal injury, you may need to place the straps above or below the injury. But never place them tightly across the abdomen. And this is how they want this done. You'll notice that they've got an X on the chest, they got an X on the pelvis, and then they got one across the lower legs. And this appears to be a smaller or pediatric patient, so they didn't need to use quite as many straps.
One, two, three. Okay, good. You do an X over the shoulder and towards the hip and then over the legs. Okay, let's put some padding between his legs here.
Are we ready?
Yeah.
Okay, so they didn't quite get the lower X on the pelvis, it's more on the legs. And that strap around the feet and ski boots is a ski patrol trick that helps prevent the patient from sliding down the board as they're going down the hill on the toboggan. Continuing with Skill Guide 21-4, securing the patient. Secure the head last. If you are using a commercial head immobilization device, head blocks, follow the manufacturer's directions. If you're using towel rolls, roll 2 standard towels and securely tape each roll. Place 1 towel on each side of the patient's head. Secure the head by placing a large piece of tape or cravat over the patient's forehead. Be sure not to cover the eyes. Place a second piece of tape over the C-collar just below the chin. An alternative method is to place a rolled up horse collar shaped blanket around the patient's head and secure it at the chin and forehead. If you determine that the helmet should remain on the patient, use commercial head blocks or towels and strap the helmet to the board.
All right, Pierce, I'm going to get these head blocks on you.
Perfect.
Just to make sure we're touching your shoulders. And then,
Okay, 1, 2, 3. Good. Strap across the forehead. How's that feel, Pierce?
Awesome.
When using spider straps, you should remember that the top yoke is generally connected to the bottom yoke, so you should get the shoulder straps on lightly and they will tighten up when you get down to the feet. The next strap on the chest goes high up, almost under the armpits. The next strap on the pelvis, another strap on the legs, and when you do the foot strap, the whole thing tightens up. It's most efficient to work with a partner moving from top to bottom down each side. If you get the Velcro straps tight enough the first time, you're not wasting time by going back and tightening them. If the patient's cooperative, it's not required to restrain their hands. And after you're done, recheck CSMs in all 4 extremities. Some pro tips on the head blocks. The pad is held to the board by these long straps. They go underneath the backboard and they get Velcroed to the pad over here. Don't take these straps off because then the pad's not connected to the backboard and you want it to be. When you put the block on the pad, you want it to be down against the patient's shoulders so that you're forming a tight unit of the head, shoulders, torso, blocks all come together. You don't want the blocks floating up at the top of the patient's head. It's probably going to end up there anyway after toboggan transport because the patient tends to slide down the backboard. So start with the blocks low against the shoulders. As you place them, roll them in towards the head. You'll notice that the blocks mostly have a flat side and an angled side. The flat side is at a 90-degree angle to the bottom of the block. You want the flat side against the head and the angled sides to the outside. We generally only use 1 strap across the forehead and we do not use a second chin strap. And that's been standard practice everywhere that I've worked on ambulances and ski patrolling. It is possible to use the chin strap. You just got to make sure that it's not exerting force on the patient's head as they're sliding down the backboard in the toboggan. So almost everywhere that I've ever seen just uses the forehead strap because the chin strap could potentially obstruct the airway. Like that. When you have the patient completely secured to the board, you need to recheck CSMs, and you need to recheck all 3 components: circulation, sensation, and motion in all 4 extremities. So each hand gets, can you feel this? Can you move this? And do they have circulation? Each foot gets, can you feel this? Can you wiggle this? And do you have circulation? Either is your foot particularly cold in the ski boot or does it feel the same? And check the skin above the top of the ski boot.